Everybody, and welcome to Tuesday Training. I hope you're having a fantastic week. As always,
we are live from Austin, Texas, right here in Insurance Syndicate headquarters, and man, we have a great show for you.
Good morning, happy Tuesday. Hope you guys are having a fantastic week so far. Guarantee I am. Gearing up for the Invictus Conference comes up this weekend, man. We are nearly a sold out show. VIP tickets, toast. There are no more. It's packed. General admission, I think we got maybe 8 or 9 general admission tickets still available before those are sold out. After those are sold, we are going to open up some free tickets for people that just want to come and see the show. They don't want to participate in the welcome party. They don't like food, I guess, so they're not going to get to eat. They don't get the VIP party, but they do get all the value and all the knowledge. So stay tuned for that. But again, I think we have about 8, maybe 9 general admission tickets still available for sale. If you are an agent who is into the Spanish language and you want to learn some stuff, come see us in Houston. May 1st, 2nd, and 3rd this week coming up. Royal Sonesta at the Galleria. It's going to be a great event. I guarantee you. We have some outstanding speakers, including Mr. Dan Gomez from the Millionaire Mindset. We also have Paula Cabrera, who is a 4-time World Cup appearance soccer player, played for the Colombian national team, the female Colombian national team, and 4-time, I believe, Copa America champion. So looking forward to hearing from some of those folks. And we got a whole host of industry leaders that are definitely ready to light you up this weekend. Come join us. Thursday is the welcome party. Starts at 7:30. We'll have some cocktails, some appetizers, and some good stuff. Before we jump in, man, and I got a lot of stuff to talk about for you guys today. There's the topic of the show, if you saw the graphic, was Medicare For All with the big question mark. And you may not have heard, but there is a renewed push for Medicare For All in a bill proposal that's getting pushed up today. I'm going to go through that with you at the end of the show. That is the crux of it. And I got some news that I want to go through that kind of builds up to that for you as well. Before we jump into that, of course, this show, I want to give a big shout out to my guys over at DFY CRM for helping sponsor the show and make this possible. They are one of easily the best go high level white label CRMs out there for the insurance industry. It's the one that I use. It's the one that I love. I absolutely adore it. With that said, man, I want to dive in because I've got a lot of news and I really want to get to this new bill that they're pushing up there for you guys. So we're just going to dive right in right off the bat. As always, we got some fraud. You know, no shortage of fraud in the Medicare space. Don't let them fool you. There's a lot of it. And right here, we've got another one. Massachusetts doctor pleads guilty to $35.5 million Medicare fraud scheme. What is he up to? Well, a Massachusetts doctor was indicted for her role in an international telemedicine kickback scheme wrapped up in another legal setback, agreeing to plead guilty to allegedly defrauding Medicare for genetic testing services that she never provided. Lathu, a Boston-based emergency medicine physician, is accused of causing third-party laboratories to submit roughly $35.5 million in claims to Medicare based on orders for genetic testing that allegedly contained false medical information. Says that Medicare paid about $25.3 million in total. And Thu, age 69, has agreed to plead guilty to 2 counts of making false statements relating to healthcare matters, a charge that carries a sentence of up to 5 years in prison, 3 years of supervised release, and a fine of up to $250,000. You guys probably remember, like, this was a big thing that was happening during COVID, but even a little bit before that with all these different genetic testing stuff that they were sending out for people that never asked for it and just billing Medicare. So there's another one there. And we have even one more right here. Physician sentenced after exploiting patients and stealing millions in a Medicare fraud scheme. This is from the Office of the Attorney General, and it says that a York County medical professional has been sentenced to federal prison and ordered to pay millions of dollars in restitution following a Medicare fraud scheme that stretches back to 2014, according to the U.S. DOJ. Rodney Yenser, age 55, was sentenced to 42 months in prison on charges of conspiracy to commit healthcare fraud, conspiracy to commit money laundering, and theft of public money. He is ordered to pay $2.993 million in restitution after having paid $900,000 towards a civil lawsuit. Says that he had previously admitted to defrauding Medicare between 2016 and 2020. And again, similar concept. Yenser, along with others, agreed to defraud Medicare by submitting medically unnecessary urine tests for chronic opioid patients at medical clinics that he controlled. Several of those clinics were stationed in York under the name Pain Medicine of York, or All Better Wellness. So there's another guy out there frauding Medicare. Like I said, there's a bunch of it, and that's just a couple of examples. I always like to point it out. But moving along, man, I got a lot of news for you guys. You have probably already heard about this one if you are an agent in the Medicare space, particularly in the Medicare Advantage space. But Elevance Health, previously known as Anthem, is slashing their Medicare Advantage marketing. As a matter of fact, if this article points out, and you've probably again already seen this because it's not brand new news. I think this came out maybe about 4 or 5 days ago. But it basically says that effective May 1st, the Blue Cross Blue Shield company, which is who owns Elevance, right, will remove nearly all of its Medicare Advantage plans from online marketing platforms, according to a notice sent to marketers on Friday. So again, just to repeat that, like that's if you have access to a tool like Sunfire or Connecture or maybe Ascend, right, or some of these different platforms that are out there aggregating plans together so that we can compare them and enroll them. You're not going to see Anthem Medicare Advantage plans on them anymore. They're out as of May 1st. So as of May 1st, if you have an Anthem plan that you want to enroll or an Elevance plan on Sunfire Connecture, it ain't happening, period. You will only be able to submit that business using paper applications. It says the company will require agents and brokers to submit paper apps for enrollees located in 22 states. The insurer will continue marketing dual special needs plans and policies sold in Florida. So if you're in Florida, you're probably okay. But if you're in pretty much all the other states, Elevance is out for digital enrollments unless maybe you're doing a DSNP plan. So, and I remember seeing the email from Elevance, right? And that they are, and really their goal is they want to go after harder on the DSNP market. Like they are all in on DSNPs. So it leads me to believe that in 2026, we probably won't see any standardized Medicare Advantage plans from Elevance. Maybe I'm wrong. I'm just speculating here, but it seems like they are trying to exit the standard MAPD market and solely focus on CSNPs, right? And it says here, it says, by removing digital tools and shifting to manual processes, and this is actually a quote from NABIP CEO Jessica Brooks Woods. She says, by removing digital tools and shifting to manual processes, Elevance Health is making it harder for seniors to make informed decisions. And yes, they are. But like I said, I think the future is that they are wanting to exit the Medicare Advantage market and just focus on DSNPs. I could be wrong, but we will find out, I guess, as we get closer to the plan bids and announcements later this year. So I will get this article in the group. You've probably already seen or heard about this. I know a bunch of agents are up in arms about it. Yeah, I mean, if I'm in certain areas where Anthem is the go-to product for me, and maybe I'm a telesales guy or I really like electronic enrollments, yeah, it's going to bug me. I can see that. You know, for us, we sell in multiple states. Elevance is a very small part of our portfolio. It pops up in certain pockets for us where it's really hot. But other than that, like this, I don't think this is going to be that big of an effect on our model. Certainly may affect some of you out there a little bigger. So stay tuned for more on how Elevance is going to kind of attack that as we go further. But again, starting May 1st, no more digital enrollments for standard MAPD plans on Elevance. Moving along. This one I like. I like this one a lot. Andrew Cuomo commits to killing the controversial Medicare Advantage plan for New York City retirees. You may have heard about this in the past, but there has been some proposals, and there's another one that they're about to push up by, I believe, the mayor of New York City, if I remember correctly, where they are going to take their retired government workers and auto-enroll them into a Medicare Advantage plan, one specific plan that New York feels that is probably in their best interest. Basically doesn't give them any choice, wipes out their choice, and that's why I don't like it, is because they deserve a choice. Following the lead, I'm going to read this out for you guys real quick. Following the lead of several other mayoral candidates, Andrew Cuomo is pledging that he would, if elected, kill the Adams administration's stalled effort to move New York City's 250,000 municipal retirees into a privatized Medicare plan that many fear would dilute their health insurance. Since taking office in 2022, Mayor Adams has pressed to make an Advantage plan managed by private insurance company the only healthcare option for the city's tens of thousands of retired municipal workers, including cops, firefighters, and teachers. That means that not only do they maybe have access to some type of retirement health plan, right, like a federal health plan, but that means they can't even get into original Medicare and maybe buy a supplement and any other additional benefits they might want. They're giving them a one shot only. That's the proposal, right? That marked a significant shift from the status quo in which the city offers its traditional retirees or its retirees with traditional Medicare and city subsidized supplements. So I'm not going to go through this whole article because it's pretty straightforward, right? They have a proposal up. It's stalled at the moment, but they want all municipal healthcare workers, or all municipal workers, in New York to all go to a one single Medicare Advantage plan. Not sure who it is. I would probably wager that it's with United Healthcare, since they're the largest insurer of elderly folks on the planet. But if he's elected, Cuomo says, no, we're going to nix that immediately. And I can appreciate that very much so, because I think that choice and access are two of the primary things that we always need to push for. And that idea that Adams is throwing up there, in my opinion, is absolutely terrible. So I appreciate that Cuomo's standing up on it. Moving along, and this one's kind of silly. I'm a big fan of Kaiser Family Foundation. Like, they put out a lot of great material most of the time, but the headline is kind of like a no shit, right? It says that standalone drug plans cover a larger share of Medicare Part D enrollees living in the most rural areas than Medicare Advantage. No kidding, because there are no Medicare Advantage plans in those very hyper rural areas. So all of those folks are going to be on an original Medicare plus a drug plan. So that's not all that revealing when they make that statement. But there is some good information in here in regards to some data, that you can see, like where people are at in different states, how much of the share of those beneficiaries are on an MA plan versus, say, a standalone drug plan. So, like, look, for example, if you look at Nevada, 99% are enrolled in PDPs, in standalone PDPs in Nevada, 99%. So that means 1% are either in a Medicare Advantage plan or maybe just don't even have a PDP at all. But that's pretty wild. So, that would tell you that Nevada sounds like a really good Medicare supplement state, right? Because generally speaking, if Medicare Advantage penetration is low, well, it's low for a reason, probably because there's not good or reputable or any plans available. So therefore, Medicare supplement penetration should be higher. So if you're an agent wanting to market in Nevada, for example, marketing Medicare supplements and standalone PDPs is probably the smart choice. Massachusetts is kind of interesting. I would think Massachusetts is the opposite, but it shows that Massachusetts is a 94% penetration rate on PDPs. California, 91% penetration on PDPs. That seems bizarre to me as well, but that's what they're saying. They're saying 91% of California Medicare beneficiaries are enrolled in a standalone PDP, not an MAPD. And then obviously you can check this chart all the way through. And these are your below 50%, right? So Alabama is the lowest one. 28% are enrolled in standalone, while 72% are getting their drug coverage through an MAPD. So I'll drop this in there for you guys. You can check out some of this data. It is good data, but it's not anything hyper revealing in regards to, like I said, the summary. Of course, people in very rural areas are going to be enrolled in a PDP with maybe a MedSup versus an MAPD because there's just nothing available. But this type of data you can use to help your marketing so that you are marketing in the right way to the right people, right? If I know I'm in an area that has a very high penetration of MedSup and standalone PDPs, then maybe that's the product I want to lead with, right? And vice versa. So I'll make sure that this article is in the group. You guys can check it out a little bit more. And then moving right along. This is an article out of, this is actually from the Harvard School of Public Health regarding a study that they did on radiation treatment in regards to cancer. And they compared it Medicare Advantage versus traditional Medicare. And I'm just going to go through it a little bit real quick with you. It says that there are significant differences in the cost and durations of radiotherapy treatment for cancer, depending on whether the patient is insured with traditional Medicare or Medicare Advantage. And again, this is according to a new study by health policy researchers at Harvard T.H. Chan School of Public Health. The findings provide the first direct comparison of radiotherapy utilization and spending between the two Medicare options, traditional Medicare, Medicare Advantage. Study was published on April 2nd. And you can look at some of the folks that were in there. But moving along, it says, obviously, MA has been gaining in popularity, now enrolling more than 50% of Medicare beneficiaries. The plan offers potential cost savings, such as lower copays, yada, yada. However, it may also impose challenges such as limited provider networks and prior authorization requirements, which are not factors in traditional Medicare. For cancer patients, these restrictions have prompted concerns about possible delays and denials in necessary radiotherapy treatments. No prior studies have conclusively shown whether these concerns lead to substantive differences in care. So, to investigate the question, they did a giant research study. They analyzed data from 31,563 90-day radiation treatment episodes. Okay, so they looked at a little over 31,000 situations where people over age 65 were getting 90 days of radiation treatment, right? They compared the number of treatments, the estimated spending, the type of radiation administered between, again, traditional Medicare, Medicare Advantage, and the study found that Medicare Advantage patients experienced on average 10% longer treatment or 10% longer treatment durations compared to their traditional Medicare counterparts, and spending for their treatments was estimated to be 4% higher. Researchers also found that MA patients were less likely to receive advanced therapies like proton and stereotactic radiotherapy. They're missing something there. It's not that Medicare Advantage doesn't cover proton and stereotactic radiotherapy, just means it comes with prior authorization. It actually kind of comes with prior authorization in original Medicare too. If you look it up, they want to verify that it is absolutely medically necessary that they need that treatment and not radio and chemo. So could be, that they're poking some gray areas there. So it's good to know the actual true facts. So a couple of things I want to talk about in this real quick. 10% longer treatment durations. Okay, if it's 10% longer, that probably costs more money for both the Medicare Advantage plan or traditional Medicare in that regards. But they're saying that MA plans were 10% longer treatment durations. Could you argue that 10% longer treatment is medically necessary and maybe they're getting a better health outcome? Like, they don't talk about that piece of it, and that kind of bugs me on this a little bit. And 4% higher. The cost of treatment, is it 4% higher for the Medicare Advantage plan or the cost of Medicare that's subsidizing those Medicare Advantage plans? Or is it 4% higher for the beneficiary if I'm using that Medicare Advantage plan versus traditional Medicare? They leave a couple of little details like that out that make this a little bit incomplete in my mind, because I could see an argument that says, hey, yes, they're getting 10% longer treatment duration, but they need that treatment duration to help them overcome cancer and get this thing fixed so that we can give them a better health outcome. Maybe not. One side of that argument could say that no, the Medicare Advantage plans are upcoding that so that they can increase the treatment period so that they get paid more. That's also a pretty solid possibility as well. But 4% higher, I don't feel like is that big a deal. Even if it were me, the beneficiary, if I feel like I'm getting a better health outcome, I'm okay with 4% higher, right? So there's a couple of gray areas they don't really hit on here, but nonetheless, articles like this are what remind me that it is important that I inform my clients and my beneficiaries about the cost of cancer, because whether it's traditional Medicare or Medicare Advantage, or even someone that's still in their group insurance, the vast majority of major medical plans are not equipped to handle the cost of cancer, period, end of story. So you should all be selling cancer insurance, or at least promoting it as part of your package, right? There are hospital indemnity plans that you can push cancer riders into, some of them as high as 20 grand. And then certainly there are standalone cancer plans. I own a cancer plan myself. I bought the Mutual Omaha lump sum cancer product that includes in situ, right? I got me a $100,000 benefit. So in the event that I get diagnosed with cancer, I'm going to get one single check for $100,000, and I can spend it how I want. I can get treatment. I can go put it all on the red at the roulette table. Doesn't matter, right? It's my money. I can do what I want with it. So good article. I'll get that in the group for you guys to check out. And then moving on, we are getting closer and closer to the crux of today's conversation regarding Medicare for All. This article just came out from Stat, right? Now, this normally has a paywall. So if I share this article, you may not be able to read it because it's usually buried behind a paywall, but I'm going to chat with you about it real quick. It says Medicare regulations hamper providers without helping patients, and Medicare is in desperate need of a DOGE deregulation. So this is an article it's an opinion article, right? And it's talking about the need for deregulation within Medicare in various ways. And certainly DOGE is the new Department of Government Efficiency that is kind of going after that. There's a bunch of stuff in here, but I'm going to go through a few quick items with you real quick. Number one, leading off, it just says MAGA loathe regulations restricting energy production and auto emissions will be first on the chopping block, but they're going to take a close look at the Medicare program as well. While Medicare is mainly a spending program, it also exerts vast power over the healthcare system via the regulations that dictate how providers are paid and conditions of participation, which is the minimum criteria providers need to meet to treat Medicare patients. Most of the stuff is a little bit further down, but this is actually pretty important here. Addressing these quality-based payment incentives diverts, actually, no, let me go back up. I'm sorry. This is the part. Medicare's alternative payment models. Here we go. This is where it starts to get complex. And you can find this information about these alternative payment models, how all this was set up. I have talked about this before. I'm probably going to do a whole nother episode on it again to remind you, but you can go all the way back to 1997, look at the Balanced Budget Act, and follow forward with all the Medicare reform. It's easy to find, super easy to find. Just do a big search on, hey, I want to look at Medicare reform since inception, but really pick it up since 97 and start looking at it. And you will see where they started to slowly implement these various alternative payment models. So it says Medicare's alternative payment models tie provider payment to quality measures. Sounds like a good idea, right? Because that means that's the whole value-based care thought process. If we can incentivize doctors to treat people based on a value outcome versus a volume play, then health outcomes and value should go up. Like that's kind of the theory, right? But providers who do not buy expensive systems, hire staff to document quality measures, risk sizable reductions in Medicare payments. Many quality measures are only loosely related to actual patient outcomes, and the Biden administration used the quality measure program to advance unrelated priorities. For example, eye doctors might receive a lower Medicare payment if they fail to counsel patients to stop smoking. Why does an eye doctor need to be counseling someone to stop smoking? And why is that tied to their Medicare payment? That seems a little bizarre. Dermatologists can be dinged if they do not screen patients for food insecurity, housing instability, transportation needs, utility difficulties, and interpersonal safety. A dermatologist, really. I'm going in there to get, a skin tag taken off or something to that effect. And then that doctor is required in order to get his full Medicare payment, he has to screen me for all that. Okay, that seems a little counterintuitive to me as well. Addressing these quality-based payment incentives diverts physicians' attention from patients' most pressing needs and increases the time they spend documenting visits in the medical record. One study estimated that the annual compliance cost is nearly $13,000 per physician, and many physicians have responded to Medicare's onerous requirements by abandoning independent practice for employment in large health systems. But it goes on. Even hospitals and large health systems are also facing greater regulatory burdens. Following an update to Medicare's Hospital Inpatient Quality Reporting Program, hospitals are required as of 2024, last year, to attest that their strategic plan identifies health equity and goals and discrete action steps to achieving these goals and outline specific resources which have been dedicated to achieving our equity goals. Hospitals must stratify performance indicators by race, income, and other social determinants of health variables and report results on hospital dashboards. Hospital executives and trustees must create and review a health equity plan annually, along with performance measures stratified by demographic and social risk factors. Hospitals may also voluntarily report greenhouse emissions to Medicare and take steps to enhance organizational sustainability. This continues to go on, talking about various regulations, and I'm going to slide down here for the last piece that says, as single-payer advocates will never tire of pointing out, the Medicare program has low administrative costs. They're talking about traditional Medicare. The traditional Medicare program has low administrative costs compared with private insurers, but increasingly, the program shifts administrative costs to providers, and a focused effort to deregulate an industry that accounts for 18% of the economy will pay large dividends. Very possible. Absolutely. I mean, one of the reasons that the traditional Medicare program has a low administrative cost is because they keep reducing the reimbursements to providers. Like doctors and hospitals are making less money under traditional Medicare, and that's why we see more and more and more of them opting for Medicare Advantage now. You know, you go back 11 years ago, it was really hard to find doctors to take Medicare Advantage plans. But over the time, as they've continued to push down reimbursements for Medicare, for traditional Medicare to doctors, hospitals, providers, et cetera, but increase it through these complex payment systems, right, on the Medicare Advantage world, then obviously acceptance and networks have grown drastically. Moving along. And remember, we're talking about Medicare for All, and that last article is shaping up in that direction. Just stay with me. Moving along, this is an article out of Bloomberg Law. It says Medicare enrollment proposals would speed shift to private care. This is a pretty good article. There's some spots in it that are like, but there's some good meat at the bottom that I want to get into with you. It says Medicare shift towards privatization could get a significant boost if the Center for Medicare and Medicaid Services embraces either of two conservative proposals that could increase enrollment in the program's bulging managed care option. Says Project 2025, Heritage Foundation's national policy blueprint, calls for an all-new Medicare-eligible adults to opt in to the program through a private Medicare Advantage plan rather than traditional fee-for-service, which has been the historic landing spot, right? So we know that when people turn 65, they become eligible for Medicare. They are opted into traditional Medicare, right? Automatically, if they're already drawing Social Security funds, right? Manually, if not. But that's the direction they go. And then once they're in that, then they can choose to go to a Medicare Advantage plan. They are talking about flipping that and giving them basically the opt-in to right into private Medicare right up front. Second one is the Paragon Health Institute, a conservative think tank, wants to require newly eligible beneficiaries to affirmatively choose one or the other. So before they even get enrolled in traditional Medicare, they have to make a choice. Do I want to go that way or that way? That's kind of already how it is to some extent, except that they have to go through traditional Medicare to get to Medicare Advantage, right? So I think they're looking at ways that they can bring that fork or that choice earlier and say, hey, before you even enroll in original Medicare and get your card and all of that stuff set up, which direction are you going? Let us know now. Quick statement here says, with strong Republican support of Medicare Advantage and the GOP-controlled Congress and White House, I think the stars are properly aligned for something like this to take place, says Robert Moffett, senior research fellow at the Heritage Foundation Center for Health and Welfare Policy. He said either proposal would be an improvement over the current system. 54% of eligible beneficiaries are already enrolled in Medicare Advantage plans, which are offered by private insurers like United Health Group, Humana, CVS. The Congressional Budget Office expects that to reach 64% by 2034. It's 2025. I had to look and remind myself. Getting old. So in 9 more years, they're looking at basically another 10% penetration increase in the number of eligible beneficiaries that are on Medicare Advantage plans. Both sign-up proposals would likely increase or hasten those MA growth projections, right? So they're saying, hey, if one of these options takes place where they move the decision fork earlier, right? Instead of having to go through Medicare to get to Medicare Advantage, you come to the fork in the road and they're like, which way you going? Tell us right now. Boom, boom, boom. That's going to obviously increase Medicare Advantage enrollment, and I think that's probably very true. The thumb is already firmly on the scales in favor of Medicare Advantage enrollment, and implementing either of these policies would exacerbate that. But if either policy is or either proposal is adopted without accompanying changes in the Medicare payment system, everybody said that the change would also weaken Medicare's overall finances, just as millions of aging baby boomers are swelling program ranks. So you're going to be stuck with the problem. If the proposals become policy without addressing MA's flawed risk adjustment system and broken payment system, which inflates plan reimbursements, then they're going to fester as more fiscal problems. I'm not going to dive into the section with Oz, but I want to get to this part down here a wee bit. It's basically an antique. Lawmakers and policymakers should ask themselves why traditional Medicare should be the default enrollment option when it's based on a 1965 Blue Cross Blue Shield model. And this was by, again, that gentleman, Robert Moffett. He's a former HHS Deputy Assistant Secretary. You're talking about something that's basically an antique, he says. And he's talking about traditional Medicare. Who would buy today? Now, think about this. Who would buy today with their eyes open a health policy that doesn't have any protection against the financial devastation of a catastrophic illness? We just keep doing it because we're used to it. Now, he's making an assumption there, that they're only going to get traditional Medicare, and that's it, right? Who would buy a policy that's just that? Well, hopefully no one, but we know that there's probably maybe about 15% of beneficiaries that are out there, plus or minus a bit, just running around with good old A and B and Medicare and nothing else. And they're either self-insuring on the 20%, or they're fortunate that they're healthy enough that they haven't had to deal with anything massive yet, right? Because generally speaking, we as advisors, we as Medicare, or not Medicare agents, because there's nothing like that, but me as insurance agents focused in the Medicare space, like we look at that and we're like, look, traditional Medicare is cool because you get the freedom of choice. You don't have prior authorizations. You don't need referrals. But yes, it doesn't protect you against financial devastation of a catastrophic illness. That's why you need a Medicare supplement plan. That's why maybe you need a little bit of cancer insurance, right? Et cetera, et cetera. So as long as they're buying a Medicare supplement, like that argument doesn't really hold water. But if we're just comparing it based on the original Medicare box versus Medicare Advantage, obviously Medicare Advantage is going to appear better immediately, right? Because you're going to get more benefits. You're going to have a max out of pocket. It includes dental, vision, hearing, drugs, et cetera, right? But he's not wrong that to a large extent, it is kind of an antique, and it needs, like even traditional Medicare needs updating, right? Catching the arc on this yet? Moving along, here we go. It's getting deep. This is an opinion, but it's a pretty good opinion. Medicare for all. These doctors say it's possible. These doctors say it's possible, but only if healthcare takes its medicine. To lower costs, doctors must stop over-treating, and Washington needs to stop playing politics with their health. So this is an article written by Andy Lazarus and Alan Roth. They are both doctors. They put this together, that it is better for doctors and for the healthcare system when more people are sick and rely on medical interventions. No kidding. So I am going to cruise down. There's a specific, actually, I want to get to these bullet points. I want to tell you what they're talking about, right? There's no sense in going through all of this other stuff. It's just cost and yada, yada. But I want to talk about how they think Medicare for All could work. What are the changes that they're talking about, right? That could make it work. Number one, changing reimbursement to reduce payments for procedures and tests while increasing payment for robust primary care. I'm going to say that again. Changing the reimbursement to reduce payments for procedures and tests, but increase payment for robust primary care. And they're talking about payments to doctors, not necessarily money out of your pocket or the beneficiary's pocket. And it says right here, if doctors are paid less to treat everything, which is what a primary care doctor does, right? If doctors are paid less to treat everything, well, they're going to do less of it. If they're paid more to talk with patients and give them choices, then more students would pursue primary care, fewer wasteful interventions would be ordered, and both cost and outcomes will improve dramatically. More and more doctors are falling away from primary care because there's not as much money in it, and they're specializing in either certain organs or certain types of care, right? Because they can certainly charge more for that type of care as well. Moving along, it says that drug companies must be extricated from the system. This means they don't finance and provide leaders of federal agencies. I'm going to say that again because I love that one. Drug companies must be extricated from the system. This means that they do not finance and provide leaders for federal agencies. So in other words, drug companies can't lobby. Love that idea. They can't finance politicians, and someone from big pharma can't be on the board or part of a federal agency that oversees that stuff. Thumbs up. They don't pay for studies in academia. They stop advertising, right? So again, same concept. They're saying big pharma cannot pay for studies in academia. That should be an obvious conflict of interest if Pfizer is paying for a study. Like, they're going to slant that study somehow. There's too much evidence of that. Just go watch the movie Painkillers. Or is it a movie or is it a series? I think it's a series with Matthew Broderick. Go watch that. They also stop advertising. Man, I would love to see big pharma no longer advertising, right? That inflates their cost, right? Convinces people to go get certain drugs that they may or may not even really need. And because they're spending so much in advertising, well, they have to charge more for the drugs, for one, right? If they didn't spend so much money in advertising, they wouldn't have to charge as much. I'm like, that seems like just simple math to me, simple economics. And their contributions to private groups become more transparent, right? So they can't secretly just give money into private groups. Next up, quality indicators for both doctors and clinical protocols must be vetted and presented in an accurate, patient-centric way. More money and resources must be directed to nutritional and lifestyle programs, and all doctors must receive proper training in those areas. So he's saying that if we can work on those, we can get Medicare for All to work. These measures would improve patient outcomes and satisfaction while saving enough money to finance Medicare for All. Adopting them would require all sides to agree to stop playing politics with our health and to say no to all gifts from the healthcare industry. Fat chance getting that to happen. I would love to see it happen, but I'm ye of little faith that we can get our political and congressional leaders to do that. I'm going to say that again. Adopting these ideas would require all sides, liberal, Democrat, conservative, Republican, independent, libertarian, whatever, to stop playing politics with our health and to say no to all gifts from the healthcare industry. But many people would lose money, and that's the rub. Still, with facts at our disposal and with an effort from patients themselves, the U.S. can have the best healthcare system in the world and one that could be enjoyed by all Americans at a low cost. Pretty interesting opinion there. And again, that is written by two doctors. Like, I'm not a math geek, and I didn't have the time on this show because I got more to talk about to go through all of the numbers that they talk about in here. but I will get this in the group for you. You can check it out, and I will probably reference this article again because I'm going to most likely do another follow-up talk on this because I want to go back and show you guys a little deeper the history of the legislation for Medicare reform, because I'm of the opinion that we are definitely headed for Medicare for all, whether they call it that or not. But we're headed towards some form of universal health care plan. And I'm also of the opinion that it's going to be modeled after Medicare Advantage, that you're going to get a universal box. Hey, this is the government issue version of it. If you like it, great. Based on your income and your taxes and your needs, that will decide your premium for it, if any, right? Or subsidies, however that works, similar to kind of a little bit like the ACA. And then you'll have private options for people that want a little more bang for their buck, so to speak. That's my thought process. And if I had to guess, I would say we'll probably see it sometime between now, or not now, but probably somewhere around 2030 to 2034. Just my speculation. Moving along. Check this out. This is getting pushed in today. I opened the show talking about this real quick. On April 29th, that's today, the Medicare for All Act of 2025 is going up. Representative Pramila Jayapal, I'm not sure if I'm saying her name right, and Representative Debbie Dingell and Senator Bernie Sanders will introduce the Medicare for All Act in the U.S. House and U.S. Senate. These landmark pieces of legislation would finally establish a single-payer national health program in the United States. Then it goes through all your little details here. So I'm not going to pull up the whole bill and the summaries, but I'm going to pull up the fact sheet for you here in just a second. But I will get this in the group. And whether you're for it or against it, doesn't matter. They give you all kinds of contact information that if you want to submit your content or your comments, your questions, your concerns, your support, your disparity of it, all of that is in there. They even advise you like, hey, if you want, write an op-ed or letter to the editor supporting it, et cetera, et cetera. And then you have some videos, and then they go through with they give you all these different social media graphics that you can use to help promote Medicare for All, et cetera, et cetera, et cetera. Right. But that is a new bill, and it goes up today. And here are the facts. Medicare for All. Now, it says the 2023 fact sheet, but the bill is called the Medicare for All Act of 2025. So I'm assuming maybe they've been working on this for a bit. The date on this, and this is from the office of Bernie Sanders. So, all right, here we go. In the midst of a pandemic that has claimed more than 1 million American lives, the need to guarantee health care as a fundamental right through a Medicare for All single-payer system has never been more apparent. The American health system is broken. Today in the United States, 112 million Americans, about 44% of the adult population, are struggling to pay for the medical care they need, while the share of adults who skip medical treatment because they could not afford it has tripled to 30%. The pandemic has made a bad situation worse. Over 1/3 of all COVID-19 deaths and about 40% of all infections in the United States have been linked to a lack of health insurance. Life expectancy in our country plummeted during the pandemic and now stands at just 76.4 years, the lowest since at least 97. In coming months, 15 million Americans could lose Medicaid coverage as pandemic-era eligibility policies end. That's most likely going to come true. We spend more on healthcare and get less, despite the fact that we are the only major country on earth not to guarantee healthcare for all and have 85 million who are either uninsured or underinsured due to high deductibles and copayments. We now spend twice as much per capita on healthcare than virtually any country on earth. According to the Center for Medicare and Medicaid Services, we spend nearly $13,000 per capita on healthcare. Meanwhile, the United Kingdom spends just $5,300 and change. Canada, $5,900. France, a little over $6,000. Germany spends about $7,300 per capita on healthcare, while providing a universal healthcare to everyone. Further, despite this huge expenditure, which now constitutes more than 18% of our gross domestic product, our healthcare outcomes are much worse than these countries. For example, our life expectancy is 4.5 years lower than Germany's, and we have the highest infant mortality rate of almost any major country on earth. Our healthcare system puts profit before people. I can continue to go on, but what I really want to show you is the fact sheet. This is a brief summary about it, or this is the fact sheet. Sorry, this is the facts based on, right, the disparities that are going. But this is the piece that I actually really want to show you. And this is section by section what they want to do. I can't go through all 11 pages of it in gross detail, but we will jump through some of it, right? It's a universal entitlement. This establishes the Medicare for All program, entitling all U.S. residents to benefits for healthcare services. It authorizes the Secretary of Health and Human Services to determine the criteria for residency. It allows any individual entitled to benefits to obtain services from the provider under the Act. Non-discrimination, standard stuff there. Enrollment mechanism, standard. But here we go. Effective dates of benefits. It will establish a 2-year transition period for the Medicare for All program that makes benefits available to all eligible individuals 2 years after the date of enactment. Provides that individuals under 19 years old and 55 or older are eligible for benefits 1 year after the date of enactment. It prohibits the sale of health insurance that duplicates the benefits under the program. It prohibits employers from providing benefits that duplicate the benefits under the program. But it does allow for the sale of insurance and employee-sponsored benefits that are supplemental coverage. It's going to be hard to supplement something if it's 0, 0, 0, 0, 0, isn't it? Let's move on. Comprehensive benefits. Here we go. Authorizes payment to providers for program benefits where such items or services are medically necessary or appropriate for the individual as determined by their treating physician or other licensed healthcare provider with the appropriate scope of practice. Lists covered benefits including hospital services, including inpatient, outpatient hospital care, 24-hour-a-day emergency services, inpatient prescription drugs, ambulatory patient services, primary and preventative services, including chronic disease management, prescription drugs, medical devices, biological products, including outpatient prescription drugs, medical devices, biological products, and all FDA-approved contraception, mental health and substance use treatment, including inpatient, lab and diagnostic services, comprehensive reproductive care, including but not limited to abortion, contraception, and assistive reproductive technology, maternity and newborn care, comprehensive gender-affirming care. All services for children are covered by the early and periodic screening, diagnostic, and treatment benefit, dental, audiology, hearing, and vision services, rehabilitative and habilitative services and devices, dietary and nutritional therapies, emergency services and transportation, early and periodic screening, diagnostic and treatment services, transportation to receive healthcare services for persons with disabilities, older individuals with functional limitations or low income, long-term care services and supports, hospice care, services provided by a licensed marriage and family counselor or a licensed mental health counselor, any benefits covered under this section that are provided via telehealth. Prohibits, here we go, this is the big one, prohibits cost sharing and balance benefits or balance billing for benefits provided through the Medicare for All program. Prohibits prior authorization or additional limitations for benefits applied through the use of step therapy. So instead of prior authorization, you're going to have to fail at treatment before you can get the treatment that the doctor says you really need. So I get that people don't like prior authorization because they feel like sometimes it limits it. And if you look at the math, like it's pretty much it's not really a major issue. Like people are making it, they're exaggerating it quite a bit. But instead of prior authorization, they want the doctor to give you a therapy that they approve that's obviously going to be cheaper, and they want you to fail at that therapy first. So they want to put your health care at risk at a higher level by maybe giving you a treatment that sucks before you can get the better treatment. I'm not sure which one of those is better. Do I want prior authorization where I just have to prove that it's medically necessary and I need it, and I'm not overutilizing benefits, and the doctor's not just upcoding me. And if I get denied the first time, I just appeal it, and 90% of those appeals get pushed through? Or do I want to try a lower grade alternative than what the doctor, I have to fail at that first? That treatment has to prove that it doesn't work. I have to deal with some side effects, maybe risk organ failure of some sort, who knows, before I get the real treatment I need. I'm not sure that's better. All right, provides the program benefits are available to the individual when medically necessary. Already the thing. Authorizes the secretary to include coverage of experimental items. I like that. Allows healthcare professionals who, by their scope of practice and licensure, can exercise independent professional judgment to override national practice guidelines if consistent with the professional's assessment of the individual. I like that, right? So this says that, hey, just because there is a national practice guideline doesn't mean the doctor has to follow it. He can use his expertise to address that specific patient. I like that. I particularly like that for some reasons that I will not get into today, especially in the next 9 minutes. Coverage of long-term care services for only one ADL. If they lose one ADL, this would cover their long-term care. Traditional long-term care is 2, right? You got to lose 2 activities of your daily living. They want to reduce it to 1 under Medicare for All. And that includes nursing, medical services, long-term rehabilitative and habilitative services, instrumental activities of daily living, whether provided in the institution, home, or community-based setting. And it goes on. Where is the money at? Bear with me just a second because I want to find the money, because this is the part that kind of freaked me out. I swore it was in this one. But basically it stated like no co-payments, no deductibles, no co-insurance, no premiums. I apologize. I'm struggling to locate it in here, but there is a section in here that talks about the cost for the beneficiary, and it is 0,000,000, which if something is 0,000,000, including for stuff like long-term care, what product as an insurance agent can I actually sell them? I mean, I guess I could sell them a cancer plan or a life insurance plan. That's about it. There is no other real health insurance. And then maybe not even a cancer plan, because wouldn't that just duplicate the benefits if they're able to get treatment at 0,000,000? I don't know. But here it is again, prohibition of employee benefits that are duplicative, right? So it amends ERISA to prohibit employee benefit plans that duplicate payment for items or services that are benefits under the Medicare for All program. I'm going to get this in the group for you guys, man. I'm running out of time here. But I wanted to sum it up with a couple of things real quick. And I will come back. I'm going to do a follow-up on this because I want to prove to you what I'm saying. Just the other day it was the Medicare Monsters group. People were talking about the fact that Medicare supplement plan rates are going up, right? More and more states are adopting the birthday rule, which, as we know, when a state adopts the birthday rule for a Medicare supplement plan, it drives up rates, makes the product less attractive, less affordable. So people were talking about that, and I made a comment, and I made a little joke. I was like donning my tinfoil hat. I said that it's all by design. It's a long-term bipartisan design to make original Medicare and Medicare supplement options and other supplementary insurance options unattractive or unavailable. In some cases, like you go to California, you can't even sell cancer insurance, can't sell hospital indemnity. None of that is on the table. If those people get in those situations, they just want them to get Medi-Cal and make them broke and put a lien on their house, maybe. I don't know, whatever that situation might look like. But I made a comment that it's a long-term by design plan to push people towards Medicare Advantage to prop up the direction for universal health care. And it sounds crazy. Like I got a bunch of people that laughed at me for it. I don't care. Not a few people are like, that's actually not a terrible theory. Well, it's not if you go back and you look at Medicare reform legislation, like I said when I opened the show, all the way back to 1997. 97 opened the door with the Balanced Budget Act that allowed them, it gave it the first time for private insurers to now contract for Medicare. I'm sorry. First time for Medicare to contract with private insurers, Humanas, Aetnas, et cetera. Before then, Medicare couldn't contract with any private insurers. It was just Medicare. And then we all sold Medicare supplement plans to prevent catastrophic devastation, right? For someone's nest egg or savings or income, whatever it might be. You fast forward from there and look at each piece of Medicare legislation. It doesn't matter if a Democrat was in office or if a Republican was in office. Doesn't matter. But every one of them grabbed the privatized Medicare puck and moved it a little bit further. And they moved it a little bit further. And while they might say on the news, oh, no privatized Medicare, we're not doing only Republicans want to privatize Medicare, and they pump this football, just like this guy was saying, right? If we want to get to Medicare for all, we have to stop that political football punting back and forth of Medicare. Politicians got to get over themselves. But you'll see them, they get on the news like, no one's going to privatize your Medicare, blah, 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 blah. But then behind closed doors, they'll pass a bill that increases funding to Medicare Advantage plans, private Medicare plans, by 8.5%, which is what Joe Biden did in 2023, right? And they're all picking on Trump because he's jumping it up 5% this year. But if you look at all the Medicare reform, again, it doesn't matter if it was a Democrat in office or if it was a Republican in office, every single one of them moved the puck down the road a little further towards privatized Medicare, which ultimately will become a universal healthcare model. Like, I guarantee it. I bet my whole profession on it. So when I tell you that it is a bipartisan effort by design to make original Medicare and Medicare supplement plans less affordable, less attractive, to push people towards Medicare Advantage and in a way to prop up an option for universal health care, I firmly believe that. And the evidence is 100% in the Medicare legislation. You just got to go back and look at it. And that doesn't necessarily mean it's a bad thing for us. It depends on how they shape that Medicare for All bill when it eventually does get passed. It's going to take a two-term president probably that wants to push on it to get it done, in my opinion, because the first-term president's only ever concerned about one thing, and that's getting reelected. So usually they're not going to do anything that pisses off their primary base. They're going to do that in the second term. Trump is technically a second-term president, but we know he's not interested in Medicare for All, right? But he is interested in privatized versions of Medicare, right? Which is why he's extending another giant payment increase to Medicare Advantage plans to push them up again and fight some of the regulation that was pushed on them in these last couple of years. It could easily be that there is a fully universal healthcare model, but we still have private options to sell, or that we have supplemental insurance to sell. Like, I've been in this business 21 years, and when I got into it, there was no Medicare plan to sell. People just got enrolled in Medicare, which I can't sell them. And I sold supplemental products that helped them. In the event that they take away original Medicare and they give everybody a universal healthcare option and that they extend to everyone, we're back to the same game, most likely, unless they do what Bernie Sanders wants to do, which I don't really think is mathematically possible, which is make it all 0, 0, 0, 0, 0. No premium, no co-payments, no deductibles, caps, et cetera, et cetera. Like, I'm not a math genius, right? I'm not an economist, but I just don't see how that is feasibly possible. So there's a good chance that we're just going to revert back to this industry like it was in 2005. In 2004 and before that, or maybe even up to like 2008, where really the only thing we had to sell was a supplemental product. And we could sell them by the plenty. There was no shortage of selling them, right? I sold hundreds and hundreds and hundreds of them until eventually now we're in this weird world where we have all these products, right? So that is the show for today, man. I am on the top of the hour. I will get I'll get all of this pushed in the group for you guys. Bear with me. I got a busy day, but I will do my best to get all of these articles pushed into the group for you. Check them out. Do your studies and stay tuned because won't be next week. I can't do it next week. I'm in a training with Blue Cross next week. I'm going to try to either do a rerun for you guys next week, or I might have someone substitute in for me. But in 2 weeks, I'm going to come back and I'm going to show you all of that Medicare legislation that I'm talking about, all the reform legislation that goes back to 97. And I'm going to prove to you that it's not this. This is a pretend thing they do on stage to get your votes. Oh, they want to private. Oh, no, they want to. No. They're all in the same game. They all want to privatize Medicare. They all want to get to a Medicare, some form of a privatized, possibly Medicare for all basis, right? And I'm going to prove to you that it is a bipartisan effort to push in that direction, regardless of what they say on stage to win your votes. See y'all next week. Have an awesome day.